Okay, hello everybody. I'm happy to see you again. Wish you enjoyed the last week lecture. Today it will be something, it might look basics, however, it's kind of very important topic, and I believe it's very important for everybody to focus, even if you have some experience. Also, you need to focus on some of the updates. So we're gonna go forward by chemomechanical shaping, cleaning, and obturation. It's a long presentation. I will go try not quick, but I will go a bit like in a quick pace. So let's do it. So roadmap for cleaning and shaping or any like root canal treatment, you should always start with diagnosis, case selection, anesthesia, isolation, access cavity. This is the thing that you need to spend some time to learn. Coronal flaring, which is very easy. Working determination, cleaning and shaping, which is most of the critical part of root canal treatment is in the cleaning and shaping part, where you have to get most of your skills in there. Then disinfection for sure, obturation and canal restoration. So whenever you start doing a root canal treatment, you always think about, you should, whenever you enter the root canal system, to think about how many canals in there. And depends on how many canals in there, on the type of tooth. And in every type of tooth, there is always kind of like differences between tooth to tooth. So you have to have a sound knowledge of anatomy. And also whenever you open, you have to have a better way or like a systematic way to look at the pulp chamber to see if there is another canal or not. Of course, having a CBCT will help a lot, but it's not in every case you can take CBCT. So if we look at this beautiful picture from different colleagues and friends, you will see how many canals, how many like teeth, even central incisor with 2 canals. Can you see here, some of the mesial root have 3 canals. If you see here some lateral canals, if you see here central incisor with another small root with another canals. So you should be always aware about other canals, okay? So there is one professor, he taught me a long time ago, he said, there is always another canal unless you prove otherwise. Again, there is always a canal unless you prove otherwise. So whenever you open a tooth and there is one canal, finish it, clean it, do your job, then spend like a minute or two to inspect the pulp chamber to see if there is another canal or not. All of these are very extra example of having extra canals in the root canal system. And if you have a loop, magnification, if you have a microscope, you will see better. Also, regardless of how many canals you find in the pulp chamber, the course of the canal going all the way down to the apex is different from tooth to tooth. And there is always like many classification, and there is always many different like routes. So you should be aware about how the canal is split inside, sometimes split and meet again, sometimes have 3 orifices at the apex. They call it Bertucci classification, wing classification. There is so many classification, but the most famous one is Bertucci classification. So you should be aware about these kind of things, even if you have it as a basic knowledge. Also, we should be aware about lateral canals. However, lateral canals, accessory canals, is not something that you can go with it with your file in it, but you will address it by your irrigation solution and obturation later. So anatomy of the pulp chamber, a guy called Kranzer and Ranko, they give us like a very good hints about when you open a root canal system, how to look for other canals. So there is something called law of centrality and law of concentricity and law of cemento-enamel junction, law of color changes. These laws, if you go and deep and read about it, you will see whenever you open a pulp chamber or any root canal, you have to look at these things, especially in the multi-rooted teeth, molar and premolars, especially in the molars. So we're going to see some pictures so you can understand. Meaning by something in the center, that means root canal system is always in the center of the tooth. So if you have a cross section of the tooth, you will find the root canal system in the middle. The other thing, the root canal system and orifices started at the cemento-enamel junction level. So you are expecting to see the orifices of the canal at that level. You're not expecting to see a root orifices deeper than that. And also it's different from a roof of the pulp chamber. Some of the pulp chamber, especially in the molar, they are like 2 to 3 to 4 millimeter chamber. But orifices themselves, they are on the level of the cemento-enamel junction. Pay attention to this. and see how it looks like. Pulp chamber always in the middle, and it's in the orifices on the level of the cemento-enamel junction. And here you see the pulp chamber, and you see the differences from the pulp chamber and the canals to the extra root. There is always like in the center. Everybody knows about, like from the PDS courses, that the access cavities are almost the same, or like the type or the shape of access cavity never changes through ages. Whatever changes is like it's getting smaller and smaller because the extra technologies we have. But if you like focus on doing the conventional access cavity without jeopardizing the tooth structure, you're still doing a good job. So it's how it looks like here in this diagram. And always, especially whenever you have a tooth had old filling, tooth have previous restoration, a tooth have like previous root canal treatment or calcification, whenever you open for access cavity, try always to get the original shape. Getting original shape will help you to find the canals easily. Whatever you need, or like what you need like to open access and find the located canals, have a small round burr, medium round burr, and a big round burr. That depends about how big is the root canal system. And also it depends like is there is a caries or not. Because if you're opening a tooth with a big caries, it's better to start with a big round burr to remove the caries first, then progress to the root canal system. After penetration, you're gonna need like taper diamond or endozy. And sometimes this burr on the right side, the golden one, it's used for like open through crowns. If the tooth came with a crown already and you need to access through the crown, you need some aggressive burr to open through that metals. Okay. Definitely, you're gonna need the magnification, illumination, ultrasonic. All of these will help you a lot to improve your work, especially in the molar teeth. So going forward, the basic step of access cavity, whenever you go straight from the tip of the tooth to the pulp chamber, as we say, you're expecting to see the orifices down the cemento-enamel junction. You're not gonna find it up here, and you're not gonna find it in the forcation, okay? After you access cavity and you get in the pulp chamber, always try to go lateral movement. No more apical movement. Try to get the shape by orifice opener, not orifice, sorry. Try to get the divergent shape by the endozy or taper diamond burr. Eventually, you have to look with the explorer to find the located canals. Then here the like systematic way to go through a pulp chamber. Go until you hit the pulp chamber. Start by moving lateral movement until you get this shape. After you get this shape in the last picture down, then you have to go for coronal flare. Here, there is one of the mistake that most of the young generation, I mean by young generation, is like either student or a young graduate, they tend, after they find the canal, they dig deeper to find other canals. And as I said before, whenever you are in the pulp chamber, all your movement is in a lateral movement. So what you're gonna do in this case, don't get confused. Immediately try to dry cotton with the sodium hypochlorite, squeeze it in there, stay for 5 minutes, take it until the bleeding stops. Then you can fill that gap with the bioceramic putty or with MTA, and put a layer of flowable glass ionomer. The one comes in a tube like composite, and cure it. Then finish your job, continue the case, and fill the case again. So as in this case, as you can see here, there is always a big and high success rate. Perforation, whenever happen, it depends on 3 factors: time, size, location. The time you do it, the faster you can. Location, if it's accessible or not. And the forcation is very accessible for you. You can see it and you can fix it. So time, size, location, the bigger the size, the worse. But here, since you are like, do it immediately, there is no time for the saliva and bacteria to come and contaminate. So it's better to fix it immediately whenever you have a perforation. Don't do that. If you have a perforation, you panic, you close it, you ask the patient to come after a week or two, then it's gonna be infected. So always try to address it at the same time, okay? Here how it looks like if you open a molar. Normally, if you find a distal canal in the center, then you have a line to the mesial side, and you find the canal in the exact mesial. This gives like a hint that this tooth might have only 2 canals. However, in the 7, you find this situation. If you open a little bit in the mesial, you go deep 1 or 2 millimeters, then you find a split for the other canals. So it's better to have a CBCT here. But whenever you have another case, B, distal canal, then you draw an imaginary line to the mesial side and you find the other mesiobuccal canal It's away from the center. That means definitely there is another canal on the other side. So put this picture of these three teeth in your mind. Always, always, you're gonna catch a canal this way, especially in the molar. Sometimes there is about 40% of the distal root having two canals. So whenever you find any canals and you draw an imaginary line between them and you see like a deviation in the mesial, in the buccal or lingual side, so you know there is like two canals in that tooth, on that root, okay? Put this picture in your mind. I think the lecture is recorded, so you can go to it again and again. It will help you a lot when you open like a molar, especially 7. Tooth number 7, there is a chance that having only one canal in the mesial or one canal that split deep down. Opening a premolar, okay. Opening a premolar, it should be always conservative, especially if there is no caries. And opening, it should be like straight in the middle. Don't go past the cusp tip, and you will find the canal easily and beautifully in there. As we said, maybe in the last lecture, if somebody remember who attended, after you open and you go to the pulp chamber, it's time to go through the canals. So going through the canals is better to start with, negotiate with a small file to examine the initial like canals. Is it like curved, calcified, or easy? Then you can start by eliminating the first curvature in the top. Removing the first curvature in the top will help you to clean better, help you not to break any files in there. So it's better always if you go around A, try to remove it with the taper diamond burr, Endozy, ultrasonic, whatever you have, you can just start and remove it in there, okay? Until we can get this shape. After you get this shape all the way down, that means you are getting your working length. That means you already get like an X-ray. So now we're starting to have your rotary files working. I know in the market there is so many systems, and it's your choice to pick up one and work with it. You have to master whatever you have, then you can try other ones. Keep jumping between files, it's not going to give you an experience enough to manage that file or to know it very well. And I went to this many times, and I see the market. There is so many files in there. So it's better to get a good one, start work with it, then you're going to know its limitation and strength, and you can add more to your system. So this is like one of the cases that after you open, locating MB2, so you can get MB2 by the help of microscope and by help of ultrasonic tip. So MB2 sometimes is very hidden, so you have to spend the time to find it. My advice here, whenever you open a first molar or second molar, whatever canal you find, clean it and finish it to the master apical file, then try to look for the MB2. Sometimes a young dentist like opened the tooth, he didn't find MB2, he gets frustrated, he spent the whole visit looking for MB2. And what happened after 1 hour or 2 hours, he get tired, the patient get tired, so the patient left. And he left without cleaning the other canal, so he will be in severe pain. So it's better always, whenever you have any difficult tooth, the canal you find, clean it and shave it, disinfect it, then keep looking for the other ones. Okay, put this in your mind. This is another like scenarios, how it looks like, conventional access cavity, locating, you see the map, and one of the laws there, the pulp chamber floor is darker than the walls. So you cannot see that differences unless you have a loop or microscope and light. So you can see this one in the right side and the left side. If you draw a line here in the middle, you're gonna find the canals, okay? So let's see this one. It's one here and one here. So if you draw a line in the middle, you're gonna find the canal in here, okay? And here you can see the obturation. It's another canals where we have like 4 canals. See this one here, this one here. If you draw a line, then there is a different split, right and left. So this molar comes with 4 canals, okay? Here another design or another tooth. You see the floor of the pulp chamber, you see the map, you see the darker side of the pulp chamber. It leads you immediately to the canal. You cannot see these things unless you have a good magnification and you have ultrasonic tips. So the access cavity through the molar will be much, much easier, okay? Another scenario, this is a tooth called like C-shaped canal. Even another molar, all the roots are joined and there is one big canal called C-shaped canal. So these canals, it cannot be like clean and shape easily. And the way you fill it, you're gonna fill it with the gun. You cannot fill it with a regular gutta-percha cones. Okay? So be prepared to have all the scenarios. So having a strong knowledge about anatomy, or whenever you are stuck with a case, book a patient with another appointment, go and read and go again for that patient, you will see a difference. Or refer him to somebody, he can manage the case and attend with him so you can learn a lot. There is a one trick in the central incisor and canine premolar laterals. Always there is something called, they call it like shoulder here. So the file goes easily, but always there is a neck here. If you have to remove this one with either a round burr, taper diamond burr, ultrasonic, Gates gliding, whatever you have. But we need to have a straight line axis down. Okay, this is very important tips. Glide path, it's very important. After you establish your working length, you know, your file number 10 or 8, go all the way down. You have to have a glide path file. Glide path file, it means like either with hand files or with rotary files. It's very important to manage the case. Your life will be much, much easier. It comes now recently in so many like rotary files in the market. They call it path file, glide path file, pro glider, so many names. But I believe having that one will help you to improve your skills and success in your clinic 100%. And this is how do you do the glide path. This is a simple one with a hand file. See the movement of his hand. You see, it's not screwing. Screwing inside the root canal system will have really a bigger problem with you. So you never ever screw the file inside. You see the movement, right, left in a small movement, okay? Then after you reach to that level, then you're gonna start like filing the canal. Look at the file, how it looks like after that. You see how the bend? So you have to respect this tooth. Having a file number 15 in this canal, you will ledge 100%, okay? Unless you are very expert, you know what you are doing. So my advice, never ever use file number 15, okay? Always 10 or 8. This is another case where you have the glide path file using a hand file, then he follow it with a rotary file. You see how easy you can manage that? You see at the apex, file goes about 1 millimeter or 2. You need to have that if you have a curved canal. Then you're gonna have like any system. You see how flexible is that file? Small and flexible. This will help you a lot in your canal, especially if you are treating molar or any curved canals. It's better to have this in your clinic. 1 stroke, 2 stroke, and he's already all the way down. Can you imagine that? And he follow with the file number 15 and then 20. Then you can order case. Then your file system, rotary system, whatever system you have, it will just follow easily. Okay? So far, so good. And very important tip here, whenever you have like a long canal or a curved canal, you try your best with your small file to go a little bit outside, about 1 millimeter outside. This one will help you a lot not to ledge in the future or not to do any elbow or any damage in the root canal system because you are already outside. So you manage to go with a small file. If your working length, for example, 20 millimeters, try to go to the small file all the way down to 21 millimeter, only 1 millimeter outside. This will help you a lot with cleaning and shaving. So go beyond the curve in a small rotary file. You will never ledge if you are out. Small file only, not 20, 25, 30. That's wrong. You will jeopardize the apical frame. Here, we just need to go with a smaller file a little bit outside. Okay, applying a rubber dam is a must for sure. We cannot argue anything anymore about that. And removing all the caries, doing very good isolation, then you can start your root canal treatment. You cannot start if the saliva is coming from everywhere or the blood is coming. You need to have this kind of picture in your, like in front of your eyes whenever you are accessing cavity a tooth with a caries. Then coronal flare, we can achieve it by Gates gliding. If you don't have a Gates gliding, you can achieve it by orifice opener. So many file systems in the market, they have this orifice opener, or they call it like orifice opener or like orifice shaper. There is so many names. Then what we want from this file is just to clean the coronal part of the pulp chamber, okay? Coronal part of the root, sorry. So it's like in this picture. So if you either use Gates gliding or you use rotary files. Rotary files is much safer and flexible, so I would advise you to use it, okay? After that, you have to attach your apex locator. Apex locator will tell you something. will tell you, are you touching the PDL or not? It's not gonna tell you, are you outside by 1 millimeter or 2 millimeter or 3 millimeter. Only it will tell you that I'm touching the PDL. Okay, so touching the PDL, so you reach the red flag on it. After that, you would draw a little bit inside, then take a picture, X-ray, okay? See how it looks like here? If it's in the red and you increase it 1 millimeter, 2 millimeter, 3 millimeter outside, apex locator would never tell you how much long you are outside. Put this in your mind. Even inside, the only thing the apex locator tell you that in and out point, touching PDL or not touching PDL. The rest depends on you, okay? Put this in your mind as well. So this number in the apex locator 3, 2, 1, it's meaningless. Only apex, the red zone is what I want from the apex locator. So when I touch the red zone, I would draw a little bit, half a millimeter or 1, then take an X-ray, okay? So there is so many studies and so many discussion in the past and even in the future. Where should I finish my obturation? Where should I finish, my cleaning and shaping? So it's always better to finish within 0.5 to 1 millimeter from the radiographic apex, okay? Because some people, we depend eventually on the radiograph eventually, okay? But if you are following apex locator, we're gonna follow the reading of the apex locator. Even the apex locator give you like 20 millimeters, a touching point in and out. It's better to go a little bit 1 or 0.5 millimeter inside to be safe, to create your like apical stub in there, okay? So somehow, if you rely on this diagram, we would like to stop here, somewhere here, okay? Because all this area, it's filled with periodontal ligament. I don't want to go there. I want to just finish my obturation. All the outcome studies found out that the better outcome coming from 1 to 2 millimeter short of the radiographic apex. It has a better outcome. If you are flush, meaning you are at the tip exactly of the radiograph, it's not a big deal, but it's better always to keep your instrument and to keep your obturation inside. Because anything touching outside, or if anything leaking outside, you might have like post-operative pain or trauma or like any flare-ups, okay? This is a video, I want you to see it. It's very important. It will show you like how to do cleaning and shaving. Enjoy the watching. So here he started with, he negotiated the difficult canal in B2 with a small file number 8. He didn't need to go all the way down. You need just to initiate 5 or 10 millimeter, whatever you can go. Then you start with this is the orifice opener. You see it? Use the orifice opener, create space, then use irrigation. Then after that, if you put your small file again, it will go all the way down. So the canal is up and down. You can see, you can push the file up and down easily. That means you are ready to go for the second file. Now you are like, you can do another hand file and another hand file. But if you can go with the rotary file immediately, that's what I like. This is how the rotary file works. So we can follow with another rotary files. There is so many systems in the market. Some comes like in 10, 15, 20, or like same sizes closer to that one with the small auto taper. And some others comes in like one file, but with a different table, okay? Here he uses a table next, so he can go with the first file. Almost the first file goes all the way down, and he start the brushing. So what my advice here, after coronal flare with the apex, with the coronal, with the orifice opener, glide path file to the working length, take the working length, then start with whatever system you have. That depends on the canal. Smaller canal and curved canal, use small taper files. Regular canal or big canal, use a bigger taper files. That's, I don't know if you understand this point very clearly or not. If not, please ask whoever like in the market, you are the one you are buying from him. Tell him, show me the difference between O4 taper and O6 taper and variable tapers, okay? But the most famous one is like O4 taper and O6 taper. That's very famous everywhere. Whoever using the Pro taper system before, it's a bigger taper actually, 07, 08, 09. So use it for a bigger canal. Don't use it for small and curvy canals. Okay. So here, like also he's completing the process. This is like a different kind of gutta percha where you have a non-standardized gutta percha and you cut the tip to the size you want. After that, he will fill this tooth with a different system. Okay. So this is like a brief about how to do cleaning and shaving using this system. As I said, systems are different in the market. There is so many systems. Use whatever you like. Okay, but you have to master it. As I say, take it, use it for many cases. Then you will see how good it works in your hand. After that, definitely you're gonna follow by mechanical irrigation, which is very important. We know that no matter how much you clean and shave, there is still like so many areas not touched in the pulp chain on the root canal system. And this is how it looks like from inside. If you inject ink inside and you get the tooth clear, you see how difficult it's from inside. So we have to rely on irrigation and activation. You can use chlorhexidine, EDTA to remove the smear layer and organic and non-organic tissues. But sodium hypochlorite is the must. You have to use sodium hypochlorite all the time to kill the bacteria and at the same time to dissolve the tissues. And if you want that system to get very effective, you need to deliver it all the way down to the root canal system. So having this needle, the side venting needle, the one open on the side, is very safe. So the old syringe, it has opening in the front. If you stick it down there and you inject hardly, it will go outside. So it might have a problem with the patient having like sodium hypochlorite accident. But this needle is very safe. And there is other needles, which is plastic. It has an open on the side and it can go around the curve because the metal needle cannot go around the curve. Also, we have to have some activation sources. Activation, I will show you a video how that works. Look at this video, please.
For each intercanal irrigant used. When the clinical procedure has been completed, firmly support the contra-angled nick of the handpiece and remove the attached activator tip by grasping the large circular clean guard portion with fingers and snap off. Next, remove the protective barrier sleeve. Discard the activator tip and barrier sleeve as they are for single patient use only.
So this one, I believe in the market, you have some
hydrodynamic phenomenon below the orifice. Let's look at a simulated root canal system. A vibrating tip generates intracanal waves.
So look how it does inside. So you go in the main canal, but the solution will go to the isthmuses, to the lateral canals.
Then collapse in what is termed an implosion. Implosions radiate shock waves that promote deep lateral cleaning. Studies have shown that fluid hydrodynamics produces cleaner root canal systems. Logically, better cleaning improves the potential for three-dimensional obturation and long-term success.
Perfect. I've been using this for more than 14 years now, and I still have the same machine 14 years now. So it doesn't break, it doesn't you need only to change the battery. It's very amazing machine. Also, you can, if you are like, you cannot have that machine, simply buy this tip, attach it to your clinic. Then you can have file number 10 or 15 or 8, cut it, and attach it to this machine. It will work and it can do the job. If you don't have any of these, you can have the master cone and do bumping action. Bumping action will help a lot, but it's very difficult and it will get tired. If you are working in many teeth in the same day, doing the activation with the bumping with your hand and finger, it's very difficult. So this part is done, the cleaning and shaping and access cavity, irrigation. So now let's focus on the obturation part. So a case came like this, for example, to my clinic with a big lesion and this beautiful obturation. So if it's this in your clinic, what should you do? Will you do retreatment? Will you do extraction? So tell me, can somebody answer me in the message? So a case like this, the patient apical, okay, this is one of the good options. Normally, it's better to do retreatment, clean the infection, do apical plug, then you can do the surgery immediately or wait a few months until the lesion shrink a little bit, then do the surgery. But the patient, he doesn't have money. And I told him, you might lose the crown because the crown is not that perfect. And he said, I have no other option. So what we did an apicoectomy, and this is how it looks like. And this is 1 year recall. The message from here, that's you need to have a retreatment at the beginning, okay, and have a good obturation before you perform a surgery. Otherwise, if you're stuck in a case like this, patient cannot afford, he already has a crown, he will lose everything, then you can give him a surgery as like a temporary solution, but you tell the patient, one day this will leak or some problem will happen, so he can be ready for that, okay? So having a good obturation is one of the keys. If that case have a good obturation from the beginning, we would just do the root canal the surgery, and we are like kind of trusting our conclusion. But a case like this, I know the infection inside, I know that's very poor obturation, but no other option here in this patient. This is another cases. I did a root canal treatment, everything looks fine to me. Then the patient came and there is a lesion, it failed. The message from here is like, no matter who you are, no matter how better your job, failure is there. There is always like a chance of failure. So I did the treatment and hopefully the patient is doing good so far. This is other cases where the patient have, who knows what this anatomy is. Patient came like this, 2 teeth on the other side. They have this poor treatment. So this is after my treatment. I spent like a hell of a time. I did so many things. Perfect. This is how it looks like from inside, torodontist. And if you cut the case from the beginning, you might do a good job like this. But having a retreatment, it will give you like a difficult job. Look at this case. I try to do the retreatment. I open. This is how it looks like through the microscope. I clean everything. It's attached. So it becomes like a big C shape. You will never expect this shape from the preapical X-ray. Then eventually this is how it looks like in the obturation. Then in the X-ray, it looks very ugly. So obturation, actually, it's like your ID. You are amazing, you are beautiful, or you are handsome. Then when you go to have your official ID, your picture comes like that. This is what happened with obturation. People judge you by your obturation, how it looks like in the X-ray. Nobody knows how much effort you invested in that tooth. Did you do it in a right way? Did you irrigate? Did you respect the biology? Nobody knows anything about that. So people will only judge you from the picture. So do your best to have your obturation looks amazing in the X-ray by having a good obturation system and by having a good sealer, okay? Root canal system from inside, as we see, it's very complicated, more than you imagine. Any endodontist, he knows that. I will take you to a trip inside the root canal system, how it looks like after obturation. This is one of the projects we did in our residency program. You take many teeth type, you do cleaning and shaping, obturation with different system, then you do clearing. Clearing meaning that you put the teeth in different like solution, and it becomes very the hard tissue will go away. It becomes very transparent, so you will see your obturation from inside. Look at this, how it looks like. This is my cleaning and shaping, obturation. Then after we do the clearing, you see these spaces in the middle are filled with a sealer. See how it looks like? That's mean it's not in the X-ray, people will see, and you will see only the cone, the gut pressure cone, but nobody will see what's in the middle between the root canal system. So if this part filled with bacteria and debris, this root canal system eventually will fail, okay? So that's why we focus on like doing activation very well and very nice activation. It's another tooth, how it looks like. You see the communication between the two mesials? Very amazing. You see the lateral canal and the distal, how it looks like. Another tooth. See after the clearing, see this big lateral canal going all the way down there and the sealer going out. Another tooth with a separated instrument. I separate a file or broke a file there. So whenever you have a separated file in one of the root canals, and especially if it's at the end, don't get frustrated. Just finish your cleaning and shaping, irrigation very well, and do the obturation. Look how beautiful it looks here. Amazing. And look at this canal tooth here. I want somebody to tell me there is extra anatomy here and extra anatomy here. Can you tell me which one is a ledge? The one in the top or one in the bottom? Can you answer that? So here, this looks like a natural normal anatomy, because if you go with the file, a ledge is not going to happen in the inside curvature. A ledge will happen on the outside of the curvature, because the file system I was using there, it must be very aggressive, and I wasn't that expert at that time, so I ended up by having a big ledge here. See it? But eventually, thank God, I didn't go outside. So pay attention. Ledge happen on the outside of the curvature, not inside in the curvature. Okay, always outside. This is another tooth as well. I will show you all the anatomy, how it looks like. We filled this with different kind of obturator system. I will show you how it looks like later. See how it looks like. You see the communication between the canals. See the lateral canals here. This is another tooth. This tooth is fresh. We talk it fresh, meaning by extract. The tooth was just extracted, and we did the treatment immediately. So look how it looks like from inside. See, this is the periodontal ligament outside. You see the mesial root, how it looks like? It's completely joining. See? And this is the distal. Even in the distal, you see another lateral canal in there. Beautiful. So all of these, just to show you, like to tell you how it looks like from inside. So the X-ray, it just show you the 3 cones or the 2 cones that you put. It doesn't show you anything more. But from inside, as a dentist, you should be aware what's going on inside. That's between you and God. The patient doesn't know. Your supervisor doesn't know. So whenever you do that, after cleaning and shaping, you should do a good investment on the activation. Put the solution clearly, the good solution of sodium hypochlorite, at least 2 syringe, 3 millimeter or 5 millimeter, do the activation. That will help you a lot to kill the bacteria, to dissolve the tissue, and to have a very good obturation. So when should I obturate? When the root canal system is properly clean and shaped, patient is asymptomatic. It doesn't mean that after 1 hour of treatment, you are ready to obturate, the patient feeling a lot of pain and he cannot manage to stay. Don't force the patient to do obturation. Ask him to come another visit. Canal are dry. Sometimes you do the cleaning and shaping, you are ready, everything is fine, then you cannot dry the canals because some oozing coming from down, or you already like go a little bit outside of the root canal system, apically, so the blood come from inside, or there is a lesion down there and there is some oozing. So if you cannot get the canal dry, never ever obturate. Okay, bring the patient another appointment. So why we do root canal obturation? We need to prevent the reinfection, and also sometimes we need to prevent the percolation and micro leakage of the periapical fluid into radicular space. So if you do not do obturation, the apical, let's say you have a cyst down there. So from the cyst, the solution comes, because the difference in the pressure, it will go inside the root canal system. And if there is bacteria or any other materials in there, it will go inside the root canal system. So the infection will come again, because inside the root canal system, there is no blood, there is no immunology, so the infection will develop again. So we do obturation to prevent reinfection in general, okay? We need gutta percha. There is so many instrument and material. There is silver point, if you are aware about it. Silver point comes like as a metal, and it cannot fill the irregularities, okay? And there is gutta percha, where everybody using this recently. Sealer, you can use a resin-based sealer, H28+, bioceramic sealer, MTA-based, all these things. And bioceramic, MTA-based sealers, almost the same, but the different in the name. It's like from the same family, okay? So you'll find like a sealer-based, like bioceramic sealer-based, either bioceramic or MTA, all like almost the same, different companies. So sealer can be in tubes. Either it comes powder and liquid, or 2 tubes, so you can mix it. It comes like in a syringe as a ready-made, or like there is a mixer inside, or it comes like as a bioceramic sealer or MTA sealer, so that you can inject in the canal and fill the canal later. The gutta percha is very important to know what you have. It's always better, whatever system you have, file system, to have the matching gutta percha. And you need to be aware about the taper, O2 taper, O4, O6. This is O2 taper, the original one that we know, and the one we use as lateral condensation. Here, the O4 taper, as written here, and that fits your file. If it's your file O4 taper, use O4 taper. And there is O6 as well. And there is other system. This conventional, which looks very small like this. This system-based. This is like follow the pro taper system. This is carrier-based, where there is a stick and there is gutta-percha on the top of it. So many things in the market. So pick up whatever suits you and whatever available and have a good training on them. And also we have the injectable one. This will be needed when we use warm vertical condensation, where you cut very deep. Then you have to fill the rest of the canal with the gun. We're going to show you all of this later. We need any machine that have a cutter. We used to fire like a lighter and we heated the metal and we cut. This is not clean and it causes a lot of damage in the clinic. So it's better to buy a machine like this, heat cutter. We press on the button, the tip become hot, so you can get the gutta-percha. Then you have the condensers and pluggers, you can condense. This is the injectable materials, and this is like Calamus, and there is Obtura, there is BNL, so many systems that you can put the gutta-percha pellet and you can inject it in the root canal system. As we can see here, and everybody knows, there is either lateral condensation technique, one vertical condensation, and carrier base. And also we can show you single matching cone, which is the one I'm using and so many people are using these days. This is lateral, everybody knows. I will show you here how it looks like the other system. This is one vertical condensation. Before you start, you need to check the plugger. If the plugger can go all the way down to 5 millimeters, for example, or not. See, the plugger can go here to this level, perfect. Another plugger can go all the way down to 3 or 5 millimeters. So now you are ready to do the one vertical condensation technique. You put the gutta-percha, make sure that goes all the way down to the working length. Then you apply the sealer. Cut the tip. Sometimes it's better to cut a little bit of the tip so it cannot go outside. Apply the cone with the sealer inside. Okay, see how slowly and gently. Now he put the sealer with the paper point. Then he put the cone later. There is so many ways to put, either with paper point, with file, or with the gutta-percha itself. So he applied the cone now inside. So now can we cut with the heat from here? To condensation with the condenser. You get the heat source and you cut again deeper. This they call it continuous wave. So continuous wave, one vertical condensation is almost the same. Okay. The idea, the name coming from warm vertical because we use the heat down there to carry the gutta-percha down. Condensation. So if you want to do this system perfectly, you have to have a different size plugger, and you have to have a cutter. You need to have a gun. So it's like costly. If you want to buy good machines, it will cost you a lot of money. It is very technique sensitive, and it will take more time with you. But it's one of the best systems. It doesn't mean that if you don't do that, your treatment will fail. No. Lateral condensation is working, single cone is working, one vertical is working. But if you ask me which one is the best clinically, I would choose this one. However, the recent one that comes with like bioceramic sealer, it's very promising. And there is so many studies that prove it's really good. So he brings the gun now, and he injects the gutta-percha, as you can see now. So the gutta-percha, when it's hot, it is condensable. So you can condense it and it will fill the space. If the space is round, if the space is optical, space is like a tear shape, if it's like there is isthmuses, this is the benefit about condensing the gutta-percha when it's soft. Okay? So this is a technique, one vertical condensation. I'm gonna go for the other one. This is the carrier-based obturator. You put it there and you cut it. I will show you how to do it. This is the machine. So after you verify, you make sure that.
The important thing to notice here is how slow it goes in. It doesn't need to be rapid and aggressive placement. When you think you're going too slow, you're going just right to the apex. The other thing I would do clinically that's just a little different than the video shows, there would be a paper point in the mesiolingual canal to prevent any gutta percha from going over and clogging that orifice, just making it a little bit easier to prevent any blockage right here. And again, now you can see this one's being placed with the cotton pliers, facilitating access. And that is my method of choice. So when it comes out of the oven, I'll grab it with the cotton pliers, break the handle, and place this way. Provides just that extra few millimeters of access so the handle isn't getting in the way. We can see that the carrier is being severed with a sharp spoon. And removing a little bit of the extra gutta percha. Now in the distal canal, that's quite broad, facial lingual. So as the carrier goes into the distal canal, there's going to be a little bit of condensation and downpacking that you're seeing here as well.
Place gutta core into the root canal system in one smooth motion without excessive force. The cross-linked gutta percha cord centrally compacts the alpha phase gutta percha with a hydraulic force that sends it flowing in 3 dimensions into laterals, isthmuses, and accessory canals.
Okay, this is how it looks like. And actually, I'm not a fan of them. So because it's one shot. Actually, you put this one in the machine, you heat it up. You already have the measurement, the working length. Then you shuffle it in the root canal system and you cut it. What I don't like about it is one shot. Sometimes if you missed, it's very difficult to clean up. It's a mess. Okay. The old system, they used to have a plastic covered with gutta percha. The new one is like all gutta percha hardcore in the middle, then a regular gutta percha on the top of it. I don't see so many people using this system. I don't like it myself. So let's jump to the single cone, which is very, very practical. And I would advise everybody to do it, especially the regular canals. This is, namely, is a single cone, but we are not looking for single cone. We are looking for single matching cone, okay? Single matching cone, make a huge difference. So don't mess up between single cone like this one for obturation and single matching cone, which is copying the master apical file and copying the anatomy, okay? I will show you here some experiment I did. Here, if you are aware about it, this is 3504 gutta percha. This is 3506 gutta percha. I already cleaned the shape, clean and shape the root canal system, okay, to a certain number. I will show you later. But let's do testing of fitting these two cones together. Just watch with me. This 3506. I put it in the root canal system and it stopped there. It didn't go outside the root canal system. You see, it's at the tip. When I tried the 04, see how it looks like. Oops, about 5 millimeter out. So here you have to pay attention of what kind of gutta percha you're using. So what I did, I want to just show you the importance of having a good tag back and apical fit. This is 35. After I take the same tooth and I cut it from the middle. So that means the orifices is very huge in the middle, okay? It's not an apical stub anymore. Are you with me so far? So I took the tooth after cleaning and shaping and I cut it about 5 to 6 millimeter, okay? What I did, I put the cone, the 3504, and it goes all the way down about 7 millimeter. Then I put the other cone, 3506, the tip the same, but the taper is different, and it goes out about 3 millimeter outside. What I did next, I take the extra gutta percha and I cut it from the 3504 and from the 3506. Then I fit them again and I take this picture with the microscope. So can anybody told me this is left, this is right? Which one is 3506? Which one is 3504? And which fit you like the most? The big fit or the small fit? Which one is 3506? Which one is 3504? Yalla, quick. Left 04, right 06. Yalla, another one. Right 06, 06. Okay. I'll show you now. So the one on the left is the 06. And I don't know this left or right for you, but this one is 06 and this one is 04. You don't understand this, correct? I will explain more and more. If you clean the shape of root canal system, then you fit the cone. Sometimes the cone having its fit from more coronal, from the middle and from the coronal part because it has a big taper. But actually what we need to have a fit in the 3 last millimeters or in the top, I mean at the apex. That's where we need the fit. And this happening exactly when you buy jeans and you know your size is 30, for example, but after the summer you've been eating a lot, then the jeans is stuck here. It doesn't stuck in the right place. So this, when you think about this one and you think about this one, is almost the same. We need the fit to come from the apical part, exactly. We don't the fit to come from the middle or from the coronal. And this will happen by having an 04 taper or smaller taper, not the big taper. Look at another example here. After cleaning and shaving, I put the file a little bit outside. Then this how it looks like. The gutta percha should fit nicely and beautifully like this. Here I will show you some videos how it looks like after fitting the cone. So the cone here having the fit at the apex immediately. And he cut that with the heat source. You see how beautiful is that obturation and very quick. He used bioceramic sealer and he used a single matching cone that fits nicely. And there is so many studies about the root canal obturation using different systems, lateral condensation, one vertical, single cone, with ultrasonic activation or not. There is always like some voids, but all they can have like a good success rate. So we need to focus. Like single cone obturation is well-fitted gutta percha with the MTA solution or other cement is appropriate for alternative traditional lateral compaction. It will help a lot. It will make your life much easier, but by selecting a good cone, okay? So there is so many study about the bioceramic-based root canal sealers, which is very important. It's very biocompatible. It doesn't shrink. So one of the important things about sealers, you want a sealer that fit. A sealer is the one that seal the canal, not the gutta percha. The gutta percha is the carrier only. Is the material that fit the sealer around the cone, around the root canal system. Okay, so the concept behind the bioceramic sealer, MTA sealer, or this kind of sealer is to have a sealer around all the the root canal system, and the cone is like something to facilitate the sealer to go all the way around, and the cone will go in the middle. So whenever you need retreatment, you can go through it, and it will work as a hydrodynamic. When you're pushing like that object, the gutta percha cone, through the sealer that injected inside the root canal system, it will push the sealer to go to the irregularities, lateral canals, if there is any isthmuses, so it can be fit and it doesn't shrink. It's stable. So that's what they claim, and there is very good outcome about it. So the overall success about like 96% of too many like bioceramic sealers. So many studies that focusing on obturation with different kind of system, and it always works. Whatever system you use is about how to master it, okay? I will show you something very interesting from my student from the Phantom Lab. After they did the cleaning and shaping and obturation with lateral condensation, with single cone, depends on the case. What I did this interesting thing. I take it and I cut it under the microscope and I shave it one by one and I see it. After every 3 millimeter I cut. Look how nice and fit this single obturation. Look at this one, beautifully clean and shaped. It's a big master cone, and this is lateral condensation, and you see the sealer in the middle, in between. We would like to see something like this. This is another tooth. See how it looks like, the sealer around the corners, The gutta percha cone fitting beautifully. Here, because the canal is not round, okay, you cannot put one cone and you'll fit everywhere. So in these cases, either you depend on lateral condensation, as we can see other gutta percha, or warm vertical condensation, or we can use bioceramic sealer. So it's your choice. See how it looks like? But eventually, this is the level of the 40-year student, first time in the lab, and they did amazing job. This is a molar. Look at the molar, how it looks like. You see here the molar, because it's difficult. See how big is the distal canal, and there is some extension. You see how big is the sealer compared to the gutta percha. See the mesial, one of the canal is filled, the other one is only filled with sealer, no gutta percha. When I cut about 4 millimeter more, see the mesial, it's massive. See the other canal in the mesial, how it looks like, it's not completely round. So in this one, it's better to use bioceramic sealer. Okay, you don't know, you don't see this one, you don't know the anatomy inside. So it's better to be safe. Either do very good warm vertical condensation or use bioceramic sealer to be safe. See the distal, there is an extra canal or extra anatomy. See how it looks like? Amazing. It's like a fried eggs. Yes, I want to show you inside how it looks like. So I would advise you, whenever you have extracted teeth in your clinic, do root canal treatment to the best you think you did. Then start cutting the root and look at your job, how good you are doing. So you can evaluate yourself. This is another cases I did with a single cone. Most of my work with single cone with different sealer, doesn't matter. This case came to me with a crown I opened through many years ago. When you have something like this, it's better to open before you put the rubber down so you can know where are you exactly. After I finish, this is 5 years reports. Everything is fine. This one, because it have a lot of pressure, looks like radiolucency in the mesial and distal, periodontal more than of apical radiolucency because of the endodontic infection. So this is single cone with a regular sealer, I think AH plus sealer, not even bioceramic, and it's working perfectly, okay? In this situation, if you know if the anatomy is big, it's not round, like this one or like this one, putting a single cone, I put single cone here and I pressure it, it doesn't fill all the canal. So what we do, either you fill it with lateral condensation, or you fill it with warm vertical condensation, or you fill it with bioceramic sealer. Single matching cone is not gonna work here, okay? Unless you use single matching cone with a bioceramic sealer, it's a good solution. But in this anatomy, as I said, you have to do very good activation and irrigation in there. Another issue, if you put a single cone and you find there is an extra space, you can add lateral condensation easily. In a case like this, you can fill it with a gun. You cannot use any single cone here anymore. You have to fill it with a warm vertical light with a injectable gutta percha. Here I will show you some simple setting. When it comes to obturation, I remove everything from my table. I just leave the gutta percha cones with the paper point, sealer, gutta percha cutter or heat cutter, and condenser. I like always to do it like this. You see, when I do irrigation, after I finish the irrigation, I do suction. I suction everything from inside. Then I apply paper point, the matching for the master cone. And after I apply it, I do something very important. You have to dry. So in this trick, you can get the canal dry very fast. Okay. Clinically, I like to do myself either if I trust my assistant to do a good mix of the sealer. Otherwise, I do it myself. You have to mix the sealer perfectly like this. Unless you have bioceramic sealer or ready mixed sealer, that's another issue. But if you have powder or liquid or toothpaste, you have to mix it perfectly. Okay. And this is how you apply the sealer. Put it in the canal, go in like this motion, go all the way around, take it out. And I like to take another bite with the sealer on the tip. Okay. Then you go around again. Then you are ready to cut. Using this tooth, single cone, single matching cone. It's the heat cutter. You see how it looks like and how fast and easy it cuts. Sometimes I need to go a little bit deeper. After condensation, I go again and I cut 1-2 millimeter extra and I do condensation. No problem with that at all. Clinically, I will show you like the other video, how it looks like. It's an amazing video. I showed you before, but I will show you another picture. Let's fitting the cone. The teeth cut. very fast and quick. And here, after you take a scaler and you clean the wall. So this is my advice. After you finish cleaning and shaving and obturation, if you have the scaler tip that attach, clean everything with the scaler tip. Then after that, follow with the alcohol swab, clean and dry. Then you can follow up with your final restoration, whatever. Otherwise, if you don't have this facility, I do it the old way. You get a new bear. This is a teeth that I obturate. Take a new taper diamond bear, not the one that you open the caries with. No, a new one. And you just go slowly around the pulp chamber and around all the corner. Get it fresh touch. You see the voice. You hear the voice. That means my foot on the when I press on the machine is not one continuous press. It's that on and off, on and off. So the cut will be very minimum, just to clean the tip and to clean the access cavity, not to remove extra denting. So there is so many to clean around after you finish. Okay. So challenging is not only the anatomy. Sometimes position of the tooth may complicate the situation. Mouth opening, experience of the operator tools, and time. Sometimes you wanna finish in one visit, but it's a very difficult case. You have to spend many visits. So you have to prepare your set case, your cleaning and shaving protocol in one visit, the second one obturation, whatever you like. But this is one of the challenges you have to deal with. Eventually, magnification and illumination is very important. Some cases you cannot ignore. I will show you this case, which is very important case. In the mesial, in the buccal canal, there is two canals. And after cleaning and shaving, and it felt like this. This way, you cannot, never ever you can fill it with your bare eyes. You have to use loop or microscope. See how it looks like. I cut deep here. I put the one cone and I cut it, and I put the other cone and I cut it like this. Then I fill with the injectable gutta percha with the help of a microscope. So some cases, you have to know your limitation. If you cannot fill it yourself, just refer it to the specialists who have the material and the instrument, okay? There is very important tips here. Some taper, but different fit. Some gutta percha depends on the company. This one on the left side, the tip 3006, but when you come to the middle and coronal is 04. So that means, and this design is very smart design. It will fit only in the apical part. However, this one is very huge. The tip is the same like this one, say 3006, but it's getting huge and huge and huge. This is good for straight canals, but in curved canal, it didn't go with you around the curve. So you have to be smart when you like evaluating the instrument and the material that you have in your clinic. Okay. Some cases, the same box, you might have different gutta percha. There is error in the manufacture. So you get a gutta percha, it doesn't fit. You get another one, it fits perfectly. So always be patient. Try another more than one gutta percha before you decide is fitting or not. Master cone do not go all the way the worker length, despite that you did everything right. Irrigation, recapitulation. So go smaller and size and taper, or go smaller in taper. Sometime, because the canal is long, and when you do the gutta percha matching, you use it with the canal wet, not dry. Okay, it's very important. So the friction of the gutta percha on the walls, it prevents the gutta percha to go all the way down. Gutta percha is a plastic, not like a file. A file is a metal. When you push it, it goes all the way down. But the gutta percha, when it has friction from different dimensions, it stops. So you think it's short, and you think you did not go to your job perfectly. No, because the friction. So what you do, you go a little bit smaller size, okay? A little bit, not that much. In a curved canal, friction of the gutta percha cone. That's what I just explained right now. There is some clinical message. If it's not about the technique, as I said, there is so many techniques. It's about how perfect you do it. Some cases require specific technique and specific machine and instrument. Matching single cone, easy yet very effective if you master it. And thank you very much. I hope you enjoyed. It's very thick lecture, but I try to do it as fast as I can to save your time. So any question, guys? I'm here to answer you.